Your answer choices are A, I25.110, I20.0, Z87.891, B, I25.110, Z87.891, C, I25.110, F17.210, and D, I25.110, Z72.0. A former smoker is seen for a follow-up. He has coronary artery disease with unstable angina. Good luck, coders.
Okay, I think my clock wasn't working or I didn't push it in time. All right, so let's go ahead and let's highlight our key terms. I'm inventorying former smoker, CAD, coronary artery disease, and unstable angina. So there's nothing I can eliminate on site. So I'm just going to pull out the guideline. And there's a guideline C9B It says when you have atherosclerotic coronary artery disease, ASHD, it's the same as CAD with angina. You're going to sequence first I25.11 ASHD with angina, or if the patient has a bypass grafting, I25.7, and it says do not use a separate angina code because it's bundle, it's integral. All right, so this patient does have unstable angina, and we're still going to have to look up everything. All right, so we've established that I25.110 is correct because it's shared by all four answers. So let's go ahead and take a look. I25.110. Oh, but it's pointing me and saying, hey, read these notes here. Okay, I'm going to get to that, but I do want to look at this. Okay, it's telling me look at unstable angina. I20.0. This is the code for unstable angina. So you could use this code when a person does not have CAD because the guideline says don't code this with CAD. It's integral. All right, so I believe you, so I'm going to eliminate it. I'm going to eliminate A. Now let's go look at I25.110. I25.110. Look at this. It's telling me to eliminate these. Okay, all right. I apologize. So let's go ahead and read these notes. Up above at the boss level, there are instructional notes. And as you can see, it's telling you these diagnoses and their codes that are codable. However, it's telling us that if the patient has a history of tobacco dependence, you can code it. But our um, patient doesn't have documented a history of tobacco dependence. It just says he's a former smoker, right? So we're going to get rid of Z. Oh, wait. I apologize. It does says he's a former smoker. So let me tell you why we're going to select that. We're going to select it because it's the best of the four, right? So if you look at F17.210, F17, this is tobacco dependence. That means this patient is dependent right now, right? It's happening right now. Also, Z72.0 is tobacco use. That means that patient is using it right now. Neither of these are true. So if the only thing that we have left is history of tobacco dependence, then we code it Z87.89 because it's a history. I don't know if the patient was dependent, but it is the best of the four. And that's something that we're going to have to get accustomed to. You should not only see clinically correct scenarios and answers. You shouldn't, because when you take that exam, you're going to get thrown off because you're going to see it a lot. Yeah, your job is to pick the best of the four. Now, to me, this patient, I don't know if this patient has a history of tobacco dependence, but they do have a history of tobacco use. They definitely do. So that is the best of the four. But let's take a look at this code I25.110 that I've been trying to get to first. Atherosclerotic heart disease of native coronary artery with angina pectoris. So this code bundles or includes angina pectoris, and you should not code angina pectoris or unstable angina additionally as per the guideline. So if you said B like you all did, let's go back. Outstanding. Well, most of you did. Let me check and see. Gotta go check you out. Sometimes I can't see you. Yeah, a lot of you got that. And don't get hung up like I did. Say, oh no, it's not a history of tobacco dependence. We have to choose the best of the four. Outstanding job, everyone. All right, so I just want to end this conversation about hypertension. Remember, The 0 means no additional specified diseases. It's just hypertension. I-11 means that you have one heart. Remember, that one heart means that it's I-11. And I-12, that 2 means that you have 2 kidneys, and that's CKD. Hypertension in the setting of CKD. And I-13 means you have all 3. You have hypertension, you have heart disease, and CKD. I think you all did a phenomenal job. How do you feel? You all feeling good? Mm-hmm. Somebody said yes. Good. What about the rest of you? How do you feel about coding hypertension? More practice? You're going to blow it out of the water. And a lot of you didn't look up the codes. Just saying. Or you eliminated some answers without looking them up. Just saying. Outstanding. All right. Coders, it's time to switch gears. Now, I need your attention on this one. I do. So please, humor me. All right, so we're going to talk about acute myocardial infarction. What is that? Well, that's a heart attack, right? Yeah, and these heart attacks are usually caused by blockage in the coronary arteries, which reduces or stops the flow of blood to the heart. And that's critical. And when you have certain types of heart attacks, it damages the heart muscle. In fact, that heart muscle can die. And when it dies, it's gone, right? Okay. Now, there are 2 major types of heart attacks, an NSTEMI and a STEMI. Now, a STEMI results from the complete and prolonged occlusion or blockage of an epicardial vessel. Epicardial is a vessel that sits like right here on top of the heart. So any of these vessels that are blocked for a prolonged period of time could cause a STEMI heart attack. Now, let's say what a STEMI is. A STEMI is the acronym for ST elevation myocardial infarction. And an NSTEMI is for non-ST elevation myocardial infarction. And NSTEMIs usually result from severe coronary artery narrowing. And also, some transient occlusion, etc. So STEMIs are more complex than NSTEMI, but they're both severe, all right? And let's talk about the difference between a STEMI and an NSTEMI. All right, so STEMI really deals with these waves, right? So all of these waves mean something. So this P wave, this represents the electrical activity of the atria or atrium. The QRS complex wave, that represents the electrical activity of the ventricles. Of course, they're the lower chambers of the heart. Now, the T wave, this represents the electrical activity of the ventricles as they relax. And then the ST segment right here, this is the segment of the ECG, and it's between the Q, R, S, T. And this represents the period of time right here, the period of time when the ventricles are depolarized or recharging, right? And this is how we can tell if a patient is having a heart attack and the type of heart attack, this ST segment, right? And let me go ahead and I'm going to document this isoelectrical line right here because this is the base. This is where we want that segment to be or somewhere close, right? And anytime that ST segment is elevated, then that patient is having a STEMI, ST, elevated myocardial infarction. Now, consequently, now this is your normal ST segment, and this is your elevated ST segment. Now, consequently, when the ST segment, now this is normal, is depressed and underneath this isoelectric line, then that's an NSTEMI. Are you all with me? Somebody said, aha, that's what I'm talking about. You all with me? Good deal. And if you're not following, say, hey, Mrs. J, I don't know what you're talking about. I want to know. All right. All right. I just want one more response in the chat. Just one more. I need to know. Are you with me? Good deal. All right. Okay. So if we're looking at this right here, let's put these isoelectrical lines here. This is a normal ECG because the ST segment right here is at the base, right? It's right there. This is a STEMI. That person's having a heart attack, a ST elevated myocardial infarction. This person has an NSTEMI because it's depressed. And then this person is having an NSTEMI too, but it's inverted. Okay, so these three are heart attacks. The one at the top isn't. And if you want to see it from the actual, well, it's not, well, I guess so. You know, like if you want to just get technical here and you just read across the line, that's a STEMI, that's a STEMI, that's normal because it's sitting on the line, that's normal, STEMI. See, look at that. And if you can do that, outstanding. But now, let's go ahead and let's look at the guidelines, right? Let's look at the guidelines on how to code these non-STEMI, okay? So there is a guideline that says if a patient has a type 1 ST elevation or STEMI and a non-STEMI, let me see. I don't think this is if a patient has a type 1 non-STEMI, you're going to code it. However, if the non-STEMI evolves to a STEMI, you're not going to code the non-STEMI. You're just going to code the STEMI. And that's in a nutshell, because the STEMI is more complex than a non-STEMI, but they're both life-threatening and they're both complex. Now, let's get to the guidelines. All right, so when you are coding for an acute myocardial infarction, these are coded according to the type of infarction and the location of the infarction. When we say the type, is it type 1, 2, 3, 4, 5, or where is it located? When we say located, which artery? and where. And the fourth and fifth character spaces, they denote the type and the location of the artery. But there are two codes that you should be aware of. In your documentation, if the site and type are not specified, you're going to use code I21.9. That's an unspecified AMI, acute myocardial infarction. However, if it's a type 1 AMI, but the site is not specified, use code I21.3, and this is what they look like. I21.3, ST elevation, and this is type 1, myocardial infarction of unspecified site. So we know it's a type 1, but we just don't know where it is. And I21.9, acute myocardial infarction unspecified. We don't know the type or the site. That's important. Now let's talk about the types. All right. So a type 1 STEMI or NSTEMI, these are your most common types. Most common. These are spontaneous myocardial infarctions. They are related to plaque erosion, rupture, fissure, or dissection. So these are the most common. The code series I21.0 through 0.2 and 0.3, and an NSTEMI is I21.4. I think this is kind of written wrong. Miss Eva, if you can just make sure this should be NSTEMI right here. We might have missed that. I21.4 is NSTEMI. I'm going to try. If she can fix it, that'd be great. All right, so type 2 infarctions. These are myocardial infarctions due to demand ischemia. So you have coronary artery spasms, coronary embolisms, anemia. Myocardial infarctions secondary to ischemic balance. Type 3, other myocardial infarction associated with revascularization procedures. So sometimes when patients are undergoing rewiring or revascularization, they could have a sudden myocardial infarction due to, and have cardiac death with no biomarkers found. So this is pretty severe. Now, types 4A, B, and C. 4A is MI related to percutaneous coronary intervention. So that's another procedure that you'll learn about when you get to part 3. So I don't want to go into those procedures, but just know PCI. 4B, this is myocardial infarction related to stent thrombosis. There is a blockage in a stent. 4C is myocardial infarction related to restenosis, and their code is I21.A9. Types 3, 4, and 5. This is acute myocardial infarction related to a CABG. If a patient has, had CABG, or how can I say it? You all haven't learned it yet, but this is a procedure, or bypass grafting, where they take harvest and bypass blockages. So if the infarction is related to that bypass, then you use I21.A9. So types 3, 4, and 5 use I21.A9. But the most common is type 1. All right. All right. So here are some things you need to know. When coding acute myocardial infarctions or heart attack, duration is key. All right. So it is considered an initial infarction if the infarction is specified as having occurred within the last 28 days or less. All right, so if it's 28 days or less, it's considered an initial, and it's still an acute infarction. All right, and it is an old myocardial infarction if it was longer than 4 weeks. Let me pull this up. So that's important to know. Now, this is how you code type 1, the most common myocardial infarctions. First, you need to know why that patient came in, right? So if the patient is being admitted for an AMI, they came in the door, they're having a heart attack. This is what you need to do. You need to find out, have you had a previous heart attack? If the answer is no, your first code will be I21. If yes, it will be I22. And then I21 will be sequenced second if that AMI is less than 28 days. If it's 28 days and less, you're going to sequence it I22 first, I21 second. If it's older than 28 days, this new infarction is older than 28 days. If the previous infarction is older than 28 days, I21 followed by I25.2. And I don't expect you to remember that, right? I don't expect you to remember it. So we got charts for you, okay? And we're going to always refer to these charts while we're learning. So what if the patient came in and they had a condition that was other than AMI, and they also had an AMI? So let's say they came in, let's say they broke their leg, and while they were there, they had an AMI. Well, you are going to sequence first the reason for the encounter, that broken leg. Yep. And then second, your AMI. If they haven't had a previous AMI, right? If they haven't had a previous AMI, that's how you would do it. If they did, if it was 28 days or less, the previous was 28 days or less, you're going to sequence that RFE first, followed by I22, followed by I21. If that previous AMI is older than 28 days, you're going to sequence your RFE first, and then I21 or I25.2. It just depends. So it's really important that you pay attention to the documentation. And if it applies, then it flies. Okay, so I like this chart. This was developed by our editor for the MCG manual for 2024. I like how she did this, and it's easier to read. If the patient is admitted for an acute type 1 AMI, if they had no previous AMI, I21. If they did and it was older than 28, this is what you do. If it was not older than 28 days, 4 weeks or less, this is what you do. 4 weeks, more than 4 weeks, this is what you do. For patients admitted due to a condition other than AMI, this is what you do. Sequence the RFE first. And if they had previous AMIs, this is what you do. We'll be referencing them as we do these scenarios. And remember, RFE means reason for the encounter. All right, so I'm going to ask Ms. Stephanie to come to the fore. Well, okay, I didn't ask them how they were doing, but you all let me know in the chat how you're doing. Ms. Stephanie, please and thank you.
Thank you. Coders, a patient was brought into the ER with complaints of chest pain. The EKG showed an acute posterolateral myocardial infarction. Your time begins now to code.
Okay. I think Miss Eva and I are both tugging at this screen trying to get this Alex the alligator, Ace the alligator, to work. And also too, if you didn't know, Miss Eva, she designs a lot of these PowerPoints, so hats off to her. And she is extremely forensic. So if she sees something that's not right, she's gonna fix it. Outstanding. Okay, so what do we have here? Well, we have chest pain, and the EKG showed an acute posterolateral myocardial infarction. So we got chest pain, the acute posterolateral MI. We're going to get rid of chest pain and we're going to focus our attention on that acute posterolateral MI. So this is a type 1 AMI. Typically when they're acute like that, majority are, but if it isn't, then we'll know. So let's just assume that it is. If it isn't, when we look it up, we'll learn differently. So we have I21. It's telling us we're going to go from the I21 category. We don't know if this patient had a previous AMI because it's just not documented. And if the doctor didn't say it or document it, it did not happen for this exam. All right. So what I'm going to do is I'm going to look up my infarction. Yes, I'm going to go to my alphabetic index. I'm going to look up infarction, right? What kind of infarction? You know what? You could actually, yeah, just look up infarction and look up the type of infarction. So if you look up posterior, posterobasal, posterolateral, there you go. Posteroseptal, I21.29. There is our infarction. So let's go to our code, and we know we're in the right ballpark because it says I21. We're in the I21, and it's telling us 0.29. ST, elevation, myocardial infarction involving other sites. And if you look down, posterolateral transmural Q wave infarction acute. So that is the answer. So if you said I21.29, way to go, way to go, way to go. I love it, I love it, I love it. All right, so let's continue to test our knowledge.
Thanks for tuning in, and until next time, happy coding!